Good evening, everyone, and thank you for joining our Woo You event tonight. Our presentation is titled Scleral Lens Fitting, Setting the Foundation, and we are joined by Dr. Brooke Messer and Dr. Jamie Kuzner. Next slide. I'll be your host tonight. My name is Dr. Ariel Sorenzi. And a big thank you to Bausch & Lomb for exhibiting at this event. We'll get to hear from them at the end of the presentation, so please be sure to join for that presentation. In part 3, we're going to have a really fun knowledge series and the things that we learned from today. In part 2, and then the presentation from BNL will all be included in the knowledge part 3 presentation and event that we will have. So this will be worth 1 hour of CE credit, so please be sure to attend for a minimum of 50 minutes. For your COPE certificate, please fill out the survey link that's in the chat. It'll also be there when the webinar ends. CE certificates will be delivered via email within about 4 weeks and sent to ARBO with your OE tracker numbers. We will not have a QR code at the end of this event, just so you know, but you'll get that CE credit within about 4 weeks. We're going to have an opportunity for Q&A in the middle of the presentation and towards the end. So as you have questions, please include them in the Q&A or the chat box down at the bottom. Next slide. And then if you're on your phone, you can find the Q&A either at the top or the chat function under the 3 dots under More. So it's my pleasure to introduce our first speaker. So I've had the opportunity to meet both of these lovely ladies throughout the specialty lens world, and they're absolute rock stars in clinic, on the podium, and then they're also moms and rock the mom world too. So Dr. Messer received her Doctor of Optometry degree from the Southern California College of Optometry, and then did a cornea and contact lens residency after graduating optometry school. She's highly trained in fitting specialty contact lenses for keratoconus, post-surgical cases, and other corneal diseases, as well as multifocal and orthokeratology contact lenses. She's authored many articles for various publications and enjoys teaching other doctors complex contact lens fitting techniques and surgical co-management topics in classroom and clinical settings. She's a fellow of the American Academy of Optometry and Scleral Lens Education Society, and serves on the education committee for the North Dakota Optometric Association. And she's the advisor for the optometric residency program at Vance Thompson Vision in West Fargo,
North Dakota.
North Dakota.
Yep.
Sorry, I just lost my place. Outside the office, Dr. Messer chases around her 2 kids with her husband, Brian. She loves to golf, hike, and visit family back in her hometown in Dickinson, North Dakota. And then the next slide will show our financial disclosures. Great, and then our too short of a bio for Dr. Jamie Kuzner, so I'm going to add to it. But she is the owner and founder of the Elevate Eye Care and Eyewear in Rochester Hills, Michigan. And she cold started this practice about 18 months ago. Is that right?
2 years. About 2 years.
2 years ago. Okay, cool. And she received her doctorate of optometry from the Michigan College of Optometry at Ferris State University, and completed her residency in corneal disease and her contact lens residency at Indiana University. She's a fellow of the Scleral Lens Society, as well as the American Academy of Optometry. And one thing I wanted to also mention is that Dr. Messer and Dr. Jedlicka and Dr. Kuzner all have a podcast called Overfilled that you guys should definitely all listen to, because it is awesome, it's fun, it's educational. So I wanted to give that shout out as well. And then Dr. Kuzner has also been what was it? Top 15 of the best eye doctors in all of the US and probably the world. And
Yes.
Oh my, all the world.
2 years running.
Yeah, so you have to throw that on there too.
2 years running.
Cool. Well, I'll go ahead and show your financial disclosures, all of which have been mitigated, and I'll have you guys take it from here.
Well, thank you for that great introduction. It makes us feel just so loved and
Excited to be here with all of you. So, without further ado, I'm super excited to be presenting here with my good friend Brooke about scleral lens fitting and setting the foundation in your practices. So, for both of us, scleral lenses are a huge part of our lives and of our practice. Like Ariel mentioned, I am in a cold start practice where I see mostly scleral lens patients in private practice, and Brooke is in a wonderful specialty practice at an ODMD facility. Do you want to talk a little bit about Vance Thompson, Brooke?
Yeah, we are ODMD setting where as optometrists, we really get to practice to a high level. So I see lots of neat, complex cases. And then after their surgery is done, we get to throw a lens on top of it. So I really feel like I've learned a lot working here, really building on the foundational contact lens knowledge that I've had in the first 10 years of my career where I practiced with part of that was with Dr. Jedlicka back in Minnesota. And it's been a fun second part to my career.
And so today we're going to talk about a few different things. We're going to talk about some candidates for scleral lenses. We're going to talk about how to navigate all these fitting sets that you might have in your office, how to pick the first lens for your patient. We'll talk about some basics of just lens assessment modifications. Then we'll get into different instrumentation that you can bring into your office, some patient questions, and some of our practitioner challenges, because we all know that sometimes fitting the scleral lens is the easy part. Sometimes the hard part is dealing with the patients and your staff and billing. So we're going to talk a little bit about implementing it as well. So no matter where you are in practice, hopefully you can all take away something that you can bring in and start implementing within the next week. So just to start it out, a scleral lens, I think most of us already know what a scleral lens is. But just a brief overview again, a scleral lens is a large diameter gas permeable lens that vaults the entire cornea and limbus, and it gives a fluid reservoir that blaves the ocular surface. So this is super great for patients that have a really irregular cornea, whether that be a graft, a cone, because it's completely vaulting that surface. And what I describe to the patient, it's almost like it's giving you a brand new surface as if you didn't have an ocular disease for the most part. And it makes it very comfortable because it lands gently on the sclera. So we're not touching that cornea, which is a highly sensitive part of our body. Some great indications for it, obviously, is keratoconus, but one thing that helped me to grow my practice, and I'm sure Brooke as well, if you think outside of that keratoconus box, there are so many other patients in your practice that could benefit from these lenses. Some main ones would be corneal transplant patients, post-RK. I know in Metro Detroit, they were doing RK like crazy. So I have so many RK patients out there, and there's some of the most grateful patients with scleral lenses that you can help. Any type of other ectasias, whether that be from LASIK, other refractive surgeries, corneal scarring from trauma, issues with dry eye or other systemic disease, exposure keratopathy, which is also a great therapy for those patients, or even just high prescription patients, high astigmatism patients, or other considerations where maybe just looking at their eye anatomy. So sometimes scleral lenses could be a great indication, but at the same time, sometimes we do have to fall back on our normal gas perms, right? So we can't always jump to a scleral lens. Maybe a patient has issues with dexterity. Maybe there's motivation challenges. Maybe there's financial challenges. So we'll talk a little bit about how scleral lenses are great, but then also how sometimes we need to go back to the drawing board and go back to our roots of just a standard corneal gas perm lens. So I'm going to kick it off to Brooke for scleral lens terminology, because if you're just getting started into scleral lenses, there are so many terminologies that are out there, and it can be really confusing to know what, when you're talking to the lab, what are they exactly asking you to assess. And so I'm going to have Brooke kind of talk us through some of the common terms that you're going to come across.
Yeah, so I'm going to use the words that you would find maybe in like a paper or, again, instructional courses like this, and try and describe what those are. Because the laboratories that make their lenses, they'll come up with fancy terms for the landing curves and other technologies that the lenses can provide. And so again, these are kind of like the true terminology describing the lenses, so that when you're discussing with your consultant on how to fit the lens, what to expect, when you're working with a certain type of patient, you can, speak the same language. So first we're going to talk about sagittal depth. If you want to go ahead and click through that, thanks. So sagittal depth is the depth of the lens if you were to take the trial or the diagnostic lens out of the fitting set and put it on a tabletop, and it would be the distance from the tabletop to the apex of the lens. And so that describes your lens sagittal depth. And it's typically, from the very edge of the lens, which is usually the deepest part of the lens, to the apex. And next we have the vault. And so the vault of the lens is the thickness of that tear chamber behind the lens. Sometimes we call that the post-lens tear layer. It's the thickness of that tear layer from the tallest point or the deepest point of the cornea to the back surface of the lens. And so the vault is not always the thickness of the tear layer over the visual axis. Many times patients with corneal transplant, or excuse me, with keratoconus, that cone is inferior to the visual axis. And so that's where you're looking for the vault. Or perhaps an RK patient has some raised or nodular type scars, and you'd be looking, the thinnest vault is over those scars, even if it's mid-peripheral. So again, when we describe the vault, we talk about the thinnest vault is this amount, call it 50 microns or even 500 microns, depending on the fit. And so again, when you're describing the vault, it's the vault over the deepest part of the cornea. And then when we talk about the lens, here's an example of the vault. So when you place the lens on the eye, typically, and I kind of encourage everybody to do this nowadays. I've even gone back to placing fluorescein in the bowl of my lens prior to putting it on the patient eye. Just feel like it gives me so much information about the area of the limbus, the mid-peripheral cornea, and the apex, of course. And so when you place the lens on eye, even with white light, you can really highlight that tear layer and get a really good understanding of what the corneal shape is underneath. Next, we're going to move into chamber size. And so we talk about the lens in two sizes. One is going to be the overall diameter of the lens, which is edge to edge. And that's how most diagnostic fits will label their lenses, both in a sagittal depth and a overall diameter, and then sometimes even a base curve. But it's important to know the chamber size of the lens because our patients are going to have different size corneal diameters. And so knowing the corneal diameter and the chamber size of the lens makes sure that you have a lens that's not overly big or too small for that limbal area. Because as we'll get into, we want that lens to land just beyond the limbus. And so if you have a chamber that's smaller than the horizontal visible iris diameter of the cornea, you're obviously not going to be able to vault that limbus. And so we need to be aware of the chamber size of the lens in comparison to the corneal size. Next, we have limbal clearance. And so limbal clearance is kind of described as the angle over the landing point just past the limbus. So the lens is going to, crest over the limbus and then land onto the adjacent sclera or conjunctival surface. And then it starts to lift upward over that limbus. And so over the limbus, we gauge that area. And typically it's changed by kind of changing the trajectory over that limbal area. So when you ask for decreased limbal clearance, that angle tightens up and gets closer to the limbus. Or when you increase it again, that angle opens up over the limbus. And next we have the peripheral curves. So they'll call this the peripheral curve system, the haptics, the landing curves. And Jamie, if I missed an appropriate, feel free to jump in here. But this is usually a system of curves, maybe 2, 3 or more curves that create the landing area of the lens. And so this is the part of the lens that we want to land evenly 360 degrees around the cornea. And there's a bunch of different ways that we can improve the way that this lands on the cornea. Because our sclera, we know this, our sclera surface is not like a perfect basketball or a perfect sphere. So it's not like putting a dinner plate on a round surface. Our scleras are lumpy bumpy, they're asymmetric. And so sometimes we need to use specialty landing curves, and you can click to the next one, Jamie. This would be an example of a sclera that's a little steeper, or it kind of falls away from the practitioner as you're looking at it in the slit lamp, compared to the nasal temporal meridian. So here that superior sclera is steeper, and the curves, curve away from the practitioner. So in that area of the lens, we'd actually want those haptics to be tighter to the ocular surface. So if you go to the next one, this is just expanding that same patient. Oh, sorry, we have one more coming. This would be an example of a tight landing curve where we would want to make some adjustments to lift off and allow that vasculature to go underneath the lens. And so we would call this kind of like a tight landing area. Also a very large chamber too. If you go back, Jamie, look how far the limbus look how far the fluorescein extends past this limbus. This was during my residency, so don't hold it against me. This chamber is quite large for that corneal diameter. You can go to the next one.
Oh, I did not like that I went backwards. Hold on.
Okay.
Oh, just a moment.
Yeah.
Now it's gonna like click through all the builds at once.
Okay.
No,
Oh, yep.
sorry.
Yep.
I might not be able to get back to the rest of them,
That's
Brooke,
okay. We can talk.
without.
Pictures that were coming up next were just more evidence of those edge lifts. You can see, yep, here's a, there we go. There's a tight edge. This is an example of a lens edge that's digging into a pinguecula. So some of the lens designs have opportunities to do a focal lift over these little conjunctival lumps and bumps. So again, basically the last, handful of images that I had, they were basically demonstrating when you look at an eye and you want to look at the landing curves 360 degrees and identify where it's tight, where it's loose. A lot of the times you can fix it with just toric landing curves, so flatter in one meridian and steeper in the other to kind of lock and key that lens on the surface. And then occasionally you'll deal with some lumps and bumps like a pinguecula or a conj cyst and go from there. Another description that we use is something that we call heel down or toe down impingement. And this just talks about where within that landing system is the lens tight. And so to me, this is more of what we would call a heel down impingement. When we describe the landing curve of a lens, we describe the edge of the lens as the toe and the inner landing zone or the inner edge of those landing curves, the heel. So when we talk about a toe down impingement, you would see the lens digging in at the edge, sometimes digging into a pinguecula like that previous image. And when the blanching is closer to the limbal area, we call that heel down impingement. And so again, this is just very helpful when you're talking to your laboratory consultant to describe really what's happening. Because in this case, we'd actually bring the toe down to lift the heel up. And if you just came and said that, hey, the edge is tight, they might actually, continue to lift the toe and make that heel down blanching actually worse. So being able to describe where within the landing curves the tightness is happening, it's very valuable to the laboratory consultants.
There we go. And we got through it. That was excellent. So
Team on
I'll
to
let you take on to the fitting set navigation. So as you know, all of us have different fitting sets depending on what you have in your office. You might have one, you might have 10, right? I remember in residency, there was probably like 20 or 30, right? It's like where to pick from. So everybody's fitting set is going to be a little bit different, but they all kind of have around similar things. A lot of them are going to have different diameter options. They're going to have different sagittal depths. Most fitting sets out there now are going to have changes of sag between the lenses. Okay. I think all of the more modern scleral lenses, anyways, correct me if I'm wrong, I think they all jump in sagittal depth as you go across the lenses. But some of them might have different edge profiles as well. Some of them might just be a spherical all the way around landing zone. Some of them might already have a toricity built into them. A lot of them do. Brooke, so what's something that, how do you pick when you're looking at your fitting sets? What makes you pick one set versus another, or one lens versus another for a patient?
Yeah, so when I look at the fitting sets that I have available to me, I would think about, the type of eye that I'm working with. To me, like a simple, just a post-LASIK eye that's maybe a little bit dry. Maybe they have early presbyopia and they benefit from like a little bit of a multifocal optic. Something like that, I'd stick to, a more simple design, a little bit smaller, because I'm not anticipating this sclera or this eye shape to be all that difficult. They just need a little support on the dryness side of things, where if I see an eye that has, prior maybe conjunctival, maybe they had strab surgery and they have some lumps and bumps surgery or a scleral buckle and they have a kind of a mess on the conjunctival surface going on, then I'm going to pick a lens that maybe has more customizable options. Maybe they're quadrant specific or even more than that customizability. And some lenses have some optical options like higher order aberration corrections, multifocal optics, and things like that. So as you fit more scleral lenses, you kind of find where you like to use certain fitting sets. Another rule that I've learned from Dr. Ed Bennett over the years from the GPLI is you call it like the rule of threes. You don't try one lens from a fit set and not have a good experience and then never take that fit set again. You need to give that fitting set an opportunity to show you where it works. And so make sure you try it on at least 3 patients before you say, okay, maybe this doesn't jive with my fitting style.
That's really good advice. And I've never heard that before, but it's totally true because there's always that one patient where, you know, that one design just isn't going to work. And so if that's your only patient that you fit in that set, it might just give you a bad experience with it. But that's a really great option.
Yeah.
And if you don't know and you're brand new to fitting scleral lenses, follow the fitting guide. You know, if you don't know what to do, just all of the manufacturers have a fitting guide that if you don't know where to start by putting what their recommended first lens on and just take a look, right? If we're looking at that lens and we're looking like there's not enough sagittal depth or there's too much, then you can adjust from there. Or I remember a lot when I was at MCO, it was just, you know, grab a lens into the middle of the fitting set and just plop it on in the middle and move up or down, right? So if you don't know, just put a lens on and look at the fluorescein pattern and go from there. But we're going to go through a couple just little cases that Brooke has, and just based on the topography here, kind of walk me through what you're thinking of how to pick a first diagnostic lens for this patient, just using general topography.
Yeah, so when I look at the left image here, this is the topography image. So this is what you would get from any topographer. It would be able to generate, actually any topographer would be able to generate both of these images. The elevation map is just something that maybe we use less in primary care optometry. And then as you move into more specialty lens fitting, you'll understand what the elevation map tells you a little bit more. But when I look at a map, maps like these, first off, if I'm looking at the axial or sagittal curvature map, I like to look at the cone, where it is, and how large it is. And so to me, when I look at this cornea, so the green to me isn't all that impressive. I like to look when those colors start to get a little bit warmer. So I'm looking at kind of that yellow area. And so to me, this cone or the size of this apex is not all that impressive. It's a little bit smaller, and something also to remember is that the larger a cone is, or any area of irregularity, the deeper it's going to be. And so to me, this cone is actually pretty small, so it's not going to have an exceptional amount of depth, in my opinion. The other thing that I look at when I look at an elevation map, now this is moving to the right image, I like to know what the best fit sphere is. And so in this eye, the best fit sphere is a 730. So that's, I don't know, maybe a 47, 46, something like that. And, or maybe 48. Can't do the math. I'm sure Jason's doing the math in his head right now as he watches, but I don't quite remember what it is. But again, to me, it's in the 40s. It's not an exceptionally steep, rounded cornea. And it's the corneal apex is only 20 microns above that 7.3 best fit sphere. So again, to me, this cornea isn't all that deep. So I'm probably going to stick to the shallower side of my fitting set, at least for the first diagnostic lens. And then if you go to the next slide, now this is, just the opposite. We have a humongous apex. And the best fit sphere of this cornea is a 695, so that's significantly steeper. And the apex is 60 microns above that best fit sphere. And so to me, this cornea is big, it's deeper, so I'm going to shift to the larger size. And again, to the deeper side of my fit set. And this isn't really anything super complex. I mean, this is a big cone, so I'm going to grab something deeper, and it doesn't have to be any more complicated than that. Some of the things I used to do when I was earlier in practice, and sometimes I still do, I just look at the patient profile from the side while they're sitting in the chair looking at the acuity chart. I just look to the side, and if I can tell that cornea is ectatic just from looking at it, I'm going to grab something deep. And if I can't, then I'm going to start on the shallower end. Again, it doesn't have to be anything overly complex in picking that first lens. Something else that is helpful, or sorry, I'll let you take the next slide.
That's
helpful is understanding the depth changes between your lenses. So some fitting sets have 100 micron changes between their lenses. Others have 300 microns between lenses. And so if I have a scleral lens that's just cresting the epithelium, like it is in this anterior segment OCT, knowing that I want to have a vault of 250 microns or something like that, I'm probably not going to grab a lens that's 100 microns deeper. I probably need to go more like 300 or 400 microns deeper so that we can allow for some settling. And so that's just, if it's a 300 micron difference, then I probably only need to go one lens up in my fitting set to find the appropriate first diagnostic. But if it's only 100 micron changes between the lenses in the fitting set, then we need to make, you know, a few lens steps to find the appropriate diagnostic. And now we're going to move into some fitting assessments. Actually, this is one that I was going to take it, so I'll take this one again. I'll just try and steal the show here. So I like to look at lens position on eye, and as the first part, when I first started fitting lenses, I always went right to the vault, like where's my apex, where's the thinnest vault? But now I've actually learned that, you know, a decentered lens, whether it's temporal or inferior, that's going to affect the center of the lens, the deepest part of the lens, and how it interacts with the deepest part of the cornea. So this OCT is showing, you know, sorry, the pictures aren't that great, but in the upper picture, there's a very small amount of lens above that cornea. And then down below, it's a significantly larger area of the lens. And if you click again, there might be arrows that show up here, Jamie, because there we go. So you can see the superior part of the landing curve versus the inferior landing area is just significantly different. So this lens has significant decentration. Therefore, the apex of the cornea is not lining up with the apex of the lens, and our adjustments aren't going to be accurate. And so to me, I would need to manually center this lens with my thumb and then assess what's going on to see if the lens is too deep, too shallow, or whatever needs to happen.
And that was exactly what this video was here, but I don't think it's going to work today. But this is just a video of her manually centering the lens to take a look at it. And this is not true just for, you know, vault, but it's also for looking at your landing zone as well. So sometimes it can almost appear like you're having blanching inferiorly when there's a decentered lens. But if you actually, you know, center that lens up, it might actually just be too loose in an entire meridian. So really just centering the lens, just like you would with a corneal gas perm. If you were talking to a lab and you were describing the fluorescein pattern, they'd want to know what it looked like when it's in a centered position. And, you know, scleral lenses are not different, right? And also, if the lens is decentered, you're also going to be, you can also see that with an optic section. You're going to see issues with like fogging, debris, you're going to see conch prolapse. So just keep that in mind as well. If you have technicians, especially helping you, taking a lot of OCT images or pictures, and they're taking it without you actually looking at the broad picture of the lens, you're not going to get a true idea of what that central vault is if they're taking it in the middle when it's really a decentered lens. So this is what we're talking about, where you just kind of zoom it out completely. And that's the first thing I do as well, Brooke. I look, I'm looking for bubbles, looking for bearing, and then I'm also just looking at an overall picture of the centration. And then we're going to zoom in and look at the vault. So all of us have learned this. If you've learned it in school or if you've done any workshops, one of the number one things that you want to do is look at that vault. So what you can see in the picture here is something called an optic section. So if you look all the way on the left here, this band of black, that's going to be your lens. A lot of times that lens thickness is known. It's on the diagnostic lens itself. So say this is 300 microns or 350 or 250. You can use that as a ratio. You're kind of aiming for like a 1-to-1 ratio of that versus the fluorescein or the vaulting chamber. So ideally at the diagnostic fit, I want that vault to be about 300, 400 microns, because I know that that lens is going to settle about 150 microns, give or take, right? Depending on how squishy the conjunctiva is. So half of that settling is going to happen in the first half hour, and the rest of it will happen over the next several hours throughout the day. So you don't want to start with too thin of a vault, then have it end up landing on the cornea by 8 hours. But you also don't want to start out at, you know, 600-700 microns a volt, because it's not going to settle appropriately. There's going to be too much clearance. So the final desired volt for me is between 1 to 200 microns, depending on the lens and the eye. Obviously, it's not always perfectly going to be like that, especially if you have a very irregular cornea. But in a perfect world, that's exactly what we're looking for. And then the next thing that we're going to look at is the limbus. So another great way to look at the limbus is just by zooming out and just looking to see, you know, how far does that fluorescein extend? Does it extend past the limbus onto the conjunctiva? Yes. Then you know that that's not going to be, you know, heavily bearing on the limbus. You know that you have a large enough chamber, right? Like Brooke was talking about earlier. So looking at the limbus is one of Brooke's all-time favorite things to talk about. So I was going to let her kind of dive into the limbus there as well.
Sure. This picture here is actually, it's a lens that's more of a prolate shape, so it's, steeper in the center, over a post-LASIK eye, which is why you see so much vault in the center, and then, kind of like barely clearing, questionable clearing over the limbus, which is why that gets a little bit dark over that peripheral corneal area. And so to me, this is one that, if I were working with students or a resident, and they were asking what I would do about this limbus, I'd say, hey, let's throw in the OCT so that we can all learn a little bit what's going on here. Ideally, on nowadays, now that we have more access, that picture is quite old, we have more shapes available to us, and lenses that are automatically made for post-surgical eyes and things like that. We'd be throwing something like that on and not having to create an oblate-shaped lens, as we're going. Now, it's you don't have to put patients under an OCT to look at limbal clearance. In general, I like to put fluorescein in the bowl and just kind of see what happens, keeping in mind that a fluorescein molecule, if there's, minimal clearance over the limbus, which is sometimes just enough. Sometimes, big clearance is more of a big problem. Minimal clearance is a smaller problem. In my experience fitting lenses, typically when we have too much limbal clearance, that's another time when we'll run into issues with conjunctival prolapse, microcystic edema over the limbus, potentially some inflammation causing some neovascularization. And so in my opinion, just barely clearing over that limbus is kind of that sweet spot. And sometimes you need an OCT to confirm that it's actually clearing. These two images right here, the top left image has quite a bit of limbal clearance. And so that's where you can see that kind of little white bunching up of the conjunctival tissue. So that's some borderline conjunctival prolapse there. And then the picture down below is a lens that's actually landing on the limbus. So you can see it's, coming down at kind of a harsh angle toward the cornea. And so in a perfect world, I'd move that little angled area of the lens to the right a little bit so that we have just a touch more room to clear that cornea. And limbal things to kind of watch out for. Leftmost picture is some conjunctival prolapse. And sometimes it's hard to see if it's on a minimal level of presentation. And sometimes you can't fix all conjunctival prolapse. But if I see it in the beginning, I do try to work at it and eliminate it the best that I can. But as Jamie alluded to, the more irregular the cornea, the more challenging it's going to be to completely get rid of that conjunctival prolapse. And a lot of times it has to do with customizing that chamber to the best we can, to land just beyond the limbus as customized as we can to minimize that extra space. But again, sometimes you can't get rid of it altogether. The one in the middle is a little bit of microcystic edema over the limbal area. So the lens maybe was landing there, or maybe we have way too much clearance where we have a kind of a bogged down cornea. So we'll be watching for that. And really, we'd need to see the lens on eye to know exactly what was happening, but I don't like the way that it looks. And then the rightmost picture is sort of some deposits maybe at the edge of the vasculature, or I actually had a corneal specialist before mention that it could be possible early limbal stem cell deficiency. So it's either maybe a little bit of lipid leakage from some neovascularization or changes to the stem cells themselves. So in general, the limbus is an important spot to corneal health long-term. And so we have to, it's probably the most complicated area of a scleral fit, in my opinion. The pickier I get about how my lenses look as I go through my career.
And then finishing off the landing zone. So I don't necessarily think that the limbus is the trickiest. I think that the landing zone is sometimes the trickiest, but mostly because this is the point where your patients are actually going to complain the most, right? They don't care about the limbus. Patients really
They do not. That is true.
They do not care about the limbus, right? What they care about is midday fogging. They care about their eyes being red, and they care about lens awareness, right? So when I'm looking at all these pictures here, we're looking for areas of blanching. We're looking for areas of edge lift where there's fluorescein rapidly exchanging there, because if that fluorescein is rapidly exchanging, patients are going to get midday fogging. They're going to get lens awareness. They might feel the lens when they're blinking, and have to take the lens out and clean it multiple times a day. So a lot of times we end up having to fit someone in maybe like a toric landing zone, like Brooke had mentioned before, where maybe in this picture on the left, we might make this flatter in this meridian here, steeper in the vertical meridian, just really align it to the sclera. we know that we're really just not symmetrical people, right? Most of us aren't going to have a perfectly symmetrical sclera all the way around. And we know that the more irregular that the cornea is, the more irregular that the sclera is going to be. But our goal is to get that entire foot to land on the sclera comfortably from the toe all the way to the heel. That way we can have a nice, white, quiet eye. And I wish all my patients looked like this. I have a lot of them that look like this, but sometimes it gets a little complicated, right?
Mm-hmm.
So sometimes we need to do more of a toric or a quadrant specific lens, or maybe even a freeform lens. So the goal is to give good edge alignment without blanching, no edge lift. I don't usually want my lenses to move with the blink, but you should be able to what we call spin them after they settle. So it shouldn't be, stuck or suction cupped to the eye. I should be able to spin that lens out of rotation and have it go back easily. So even though it's not moving and pumping debris, I want it to still be loose enough that it's not causing problems. So the goal is minimal tear exchange, okay? So we still want a little bit of tear exchange there, but not enough where it's going to cause problems. So most fitting sets with scleral toricity, like we talked about, already have this incorporated. If it doesn't, you can always look at those spherical landing zones and create a toric landing zone or a quadrant specific landing zone with most of the manufacturers that we're working with. And also one of my pearls is when you're looking at your lighting as well. So this is the same eye with two different angled sources. So if you're just looking at the lens straight on, a lot of times it might look perfectly like, wow, this is a really aligned fit. It looks great. Why is the patient saying that it feels like there's an eyelash in their eye? But if you angle that light source about 45 degrees away, you can actually see that there's edge lift there. It can create a shadow. So really just taking your beam and looking at all different meridians of the eye. Or even just having the patient say, if you feel the lens, where do you feel it at? Can you point to it? A lot of times they can specifically point to the area that's either way too tight or too loose. And just talking to your patient can help you a lot with your fits as well.
Yeah, I'll have them squeeze their eye too. Like, where do you feel it? And they're like, well, I can just feel the lens. And I'll say, squeeze your eyes really tight and tell me where you can feel that edge. So that's kind of the same thing, that they can identify that area. And, when you listen to patients and kind of let them hone in, recently had a gentleman too that said, it hurts right here. And then, so of course we lift that quadrant, and then just like that, he feels better. So another thing that's helpful to, as well, when patients kind of vaguely complain about lens awareness, is to actually take the lens off after they've worn it for several hours, and then stain the eye and see where the conjunctival gutter is. See if there's any sort of creasing into the conj. There's a difference between conjunctival gutters where the lens is really digging into it, and maybe even causing some like mild conj staining because of a tight edge, versus just an impression ring. Impression rings are normal. They're just a fluid displacement, just like you get a ring on your wrist when you wear a ponytail holder or something like that. Those are normal, and it bounces back once the fluid displacement is relieved. But if you put fluorescein on and you can actually see kind of conj overlay as if it was, digging in, that's another helpful tip to find those uncomfortable edges. Lastly, when it comes to fitting, and then we're going to talk a little bit more about practice and implementation, is optical considerations around scleral lenses are just amazing these days. There are so many options, almost overwhelming at times. Retinoscopy can be a super helpful tool. These patients are hard to refract without those lenses on, but man, when you put a lens on, you can get, such a better image and at least get a starting point for your over-refraction. If they have a -8 over-refraction and you're trying to click a quarter at a time, it's going to be hard to find their best acuity. So even if you're not perfect, do retinoscopy on these patients. You'll get better with practice, and you'll actually find out that you can get fairly close and really start to hone in on their axis of astigmatism and things like that. And then if you do have a large over-refraction, just don't forget to vertex when you're ordering it with the lab. That's a common newbie error. It happens to all of us. And when it comes to astigmatism correction, if it's something less than a, 1.25 or 1.5 astigmatism, sometimes I just spherical equivalent and just order it without, especially if we're working with toric haptics or something like that that needs to incorporate rotation. So sometimes it's easiest just to put the lens on eye, and then order the spherical equivalent. When that lens comes in, assess the lens rotation, and then add in the astigmatism correction. you know, that if you have the ability to put on a toric lens in the beginning and find out where that lens will rotate to, then certainly you can add in that astigmatism if it's visually significant. But sometimes astigmatism changes a little bit as well, as you're improving the fit. So I don't chase small amounts of astigmatism until I really, really like my lens fit. And unexpected findings, another one that happens to us all is, you know, you'd clean your diagnostic lens between patients and then, oh, 9 and 10 get switched, or, you know, that kind of thing. And now you have wrong base curve on the eye, and then you get, you know, a 2 or 3 diopter miss on the patient power. So just remember that. Or if you go from lens A to lens B and the vault doesn't change as you expect, your diagnostics are probably mixed up. So thankfully, many laboratories now include markers, laser etched markers on the lenses, so that you can verify which diagnostic lens you actually have on the eye.
That is super helpful, and I think all of us have probably been there at some point. So before we move into more of the implementation, was there any questions that we wanted to jump into about the fitting process before we kind of power through some pearls for implementation?
Yes, so there are a couple of questions. Dr. Jedlicka has been awesome in answering a couple in the background. These attendees are very lucky to get to hear from another expert. So I'll just see if you have anything that you want to add to some of these questions and answers. The first one was that this doctor was mentioning that he has a difficult time with deposits in some patients appearing after 1 to 2 hours from after placing the lenses on eye. He asked if anything else might be helpful aside from using hydrogen peroxide and hydropeg coatings. And Dr. Jedlicka said it's either that the lens isn't being cleaned very well or due to some pretty significant dryness, and the importance on focusing on dry eye treatments like frequent artificial tear use, punctal occlusion, dry eye medications. Anything that you guys would want to add to that?
I have
No,
one.
I mean,
Sorry, Jamie, or I'll take this one really quick. When you have a new fitting set, the lenses don't wet very well. And so sometimes I'll grab a lens out of my fitting set. Maybe it's the tallest or the shallowest lens that we don't use very much, and those tend not to wet as much. But of course, the middle of my fitting set, those lenses wet beautifully. And so that's when I'll use like a slightly more aggressive cleaner to try and like really get that lens to wet better before it goes on the patient eye. So if it's a new diagnostic set and it's not wetting very well, perhaps you just need to keep cleaning it. So maybe even clean it, soak it, kind of break in those lenses.
yeah, and for patient lenses, a lot of times it's dry eye patients, and I'm always very upfront with my dry eye patients that this is it does not cure your dry eye. You're still going to have dry eye disease, so you're still going to have issues with your arterial film, with your glands. So now you'll just have a dry lens, right? So the lens is protecting your cornea, which is great, but you're still going to have to do all of your other dry eye treatment. So really just honing that for those patients that know that they have really bad dry eye. So really it's just treating the MGD.
Great. We have lots of questions flooding in now. So one of the questions was midday fogging. Do you find that it's mostly related to limbal clearance issues? And then what are your thoughts on adding like a more viscous artificial tear, like refreshed liquid gel into the lens before insertion? And then any other suggestions you may have for fogging. I'll give that one to you, Brooke.
I think fogging is an alignment issue, a centration issue. So it's a centering issue. First off, your lens has to be centered so that you can align your peripheral curves. Loose peripheral curves are more likely to allow for fogging. I feel like patients who have significant misalignment at the limbus are maybe more likely to see some fogging because you're kind of pushing down on that mucin creating conjunctiva. But to me, like fogging is more about lens movement and misaligned edges, that those lids are just pumping in debris every time you blink.
Mm-hmm. Great. And then for decentration of the lens, how would you be able to determine if it may be like edge lift versus towing of the edge? I'll give that one to you, Jamie.
So a lot of times I feel like now decentration is due to that overvolting the limbus, especially in a certain quadrant. So now that we have different lenses that are freeform lenses, impression lenses, dual vaulting chamber lenses, I think using those, actually working more inward to the lens and getting that to center more over the limbus versus just trying to take everything out to the very, the toe or the heel. Years ago, it used to just be, steeping it. And we were just kind of digging in that toe to try to lift the lens up. And we were doing the best that we can. But there's a lot more technologies out there now where you can use those dual elevation chamber lenses or even freeform lenses to really give that entire chamber centered instead of just the landing zone itself. So it's not necessarily heel or toe down. It's looking at the overall chamber and how that's centered.
Yeah, and
Great.
manually centering the lens is where it tells you a lot. So when you manually center the lens with, use their lower lid to kind of prop the lens up and get it to center over the limbus, and make sure you have a bunch of fluorescein in there, you're going to be able to tell, like, where is my fluorescein gushing in? Where am I seeing the impingement? Because sometimes if you're too tight nasal temporal, the lens is going to fall down because it wants to find a spot where it can kind of land a little bit better. And so again, all of those things, if you push it up into the right spot, you're going to see your tight edges, loose edges, limbal misalignments, and you may be overvaulting at that point as well if you're trying to clear an apex with a shallower part of the lens.
Great. Let me just ask a couple more questions because we do have a lot in here, but I know you guys still have a good portion of the presentation to talk through, and it looks like some of these questions may be answered in the latter half.
Okay.
So a couple of questions regarding the filling solution that you prefer to use. One in particular asked if you've ever tried to use like Regenerize or autologous serum in the bowl of the Scleral as well.
I personally don't use Regenerize. That's its own topic, but I have had patients use some serum tears, like a drop or two inside the bowl, and that is helpful. I think because it's COVID, we can't really say what we like to use the best. But I like to use salines that are actually made for scleral lenses too. So I personally am not one that's using like an Addy pack or something off label. I like to use on label solutions for my patients. These are expensive lenses. These are expensive eyeballs with grafts. So I'm gonna use the best saline that's the most sterile and safest for them. So that's what I have to say about that.
I'm not against a little bit of a viscous tear in there for foggers, but
Yeah.
I would agree with you, Jamie, that most of the time I have a specific recommendation on the filling solutions that I like, and it's not necessarily one the same all the time. We actually give the patient a kit with various of those FDA-approved filling agents, and then the patient gets to try maybe 3 or 4 of each and see if one of them feels more comfortable than the other.
Beautiful. All right. Well, I'll let you guys go ahead and take it from here, and then we'll get back to some of these questions.
Thanks.
Cool. And I might actually, just because of time, Brooke, I don't know if we should we'll kind of jump through these a little faster because I do want to get into more of like the implementation part of the presentation if my slides will start advancing. I feel like if we pause a long time, my slides don't want to jump.
Yeah, tech issues today for sure, but even if you have to pop out and pop back in, we've talked a lot about anterior segment OCT, and when it comes to do you need an anterior segment OCT to fit sclerals? I think it's really nice to have for troubleshooting from time to time, but it's not necessarily something that you absolutely have to have when you're looking at limbal clearance or maybe clearance over the a corneal transplant graft host junction. It's certainly nice to see that. We have a really nice 16.5 millimeter anterior segment OCT, so I can actually see the entire chamber. And I feel like that's been really fun, but maybe it's more of a toy than something an actual need. I'll just keep moving down the list, Jamie. Corneal topography. I do think that that's something that's really important to have if you're going to fit scleral lens as well. You need to understand the corneal size, the corneal shape, and being able to look at those elevations. There we go. And again, kind of tell you where you're going to see significant changes in corneal clearance. If you have a very, very tall part of the cornea and it gets very shallow very quickly, that's where you would see the potential for something like conjunctival prolapse, because the conj wants to go into that shallow area and kind of fill in that big void that would otherwise be filled with tear film. even if you just show our slides without presentation mode, if it's something to do with presentation mode from Microsoft.
It is because of that video that was in there. It kind of like made my whole computer go a little crazy. So I am working on it as fast as I can.
We tried to do a fancy shared PowerPoint through online Microsoft, and it's proving not well for virtual presentations, so we won't do that again. But again, when it comes to corneal topography, it's helpful when to know the shape of the cornea. And if you're going to be monitoring somebody who has keratoconus, you need to be able to accurately monitor them from a disease standpoint as well. And so I think it's valuable to have that type of technology in the practice. Other technologies that are out there are those scan-based designs and impression-based designs where you can use scleral profilometry to understand the scleral shape and build a lens from there. So nowadays there's actually technology where you can do the full scleral profilometry. You can get that 17 or 18 millimeter scan and send that in to the laboratory, and they can design a custom made lens with custom curvatures. And at that point, you're almost working more with like CAD or AutoCAD software. It's point by point software versus curves. That's one thing that I find interesting when we're doing these impression-based designs is that it, the good and the bad, right? Like you can take a video, you can take an image of the lens, but then when I look at doing some changes, I have to speak to the lab and say, hey, I see tightness here, or look at this OCT, or look at this image, because you don't always have, all of the parameters of the lens. So sometimes it's a little bit harder to change, but thankfully the technology around these types of devices are really neat in that, thankfully we don't have a lot of fit changes. And we serve a rural area and here in Fargo. And so sometimes even my more normal corneas will want a impression-based or a scan-based design simply because of time. They don't want to make a bunch of trips for adjustments. And so they feel that time is money, travel is money, and so they may as well invest it in their lens so that they can expedite that fitting experience. And then, of course, some of the more complex eyes, those types of designs are what's best for them because they're just so complex in shape. And then, of course,
looking at
Jamie,
anterior segment, I'll jump in. Now that I'm trying to get my tech issues back. Too many videos. My Mac does not like all these videos. So jumping into anterior segment photo, I love my anterior segment camera. I think it was one of my best investments in my cold start because I can just take so many pictures, send them to the lab, take pictures and look at it and study the fit afterwards, because sometimes it's like, what the heck was I writing in my chart, right? So now I'm just constantly taking pictures of the fit, really being able to study it after the patient leaves when I'm ordering the lens has been super, super helpful. So moving into some common patient questions, patients are going to have a million questions, especially on day one. So some questions that you should, have the answers to or think about in the back of your mind and let your staff know. Can I sleep in the lenses? What's going to happen if I can't get the lens out? Are these lenses going to correct my astigmatism? How often am I going to need to get a new scleral lens? And then where can I find all the supplies? So there's going to be a lot of questions. So as long as you're armed with the answers to that moving forward, but especially supplies. So in my office personally, I have all these supplies stocked, and I also sell them. I sell solution, I sell cleaners, because there's nothing worse than when your patient is so excited and they can see for the first time, and you say, oh shoot, you got to go buy this saline on Amazon and it's going to take 5 to 7 days to get to you, right? So I like to have all of the salines, the disinfectant, the plungers, everything there on hand so they can just take it, leave, start their 1 week, 2 week trial, and come back. And then that way they always know as well, like, this is what I'm recommending. I'm going to have you buy it right now so that they're not going to Walgreens or CVS and just picking up something off the shelf that's not appropriate for their condition. Some other providers
preserved soft lens solutions too, and then they wonder why their eyes sting and burn. And so it's just, we have like a form that has QR codes that takes them to the website, whether it's the product website or Amazon, like, buy this here. And at least I arm them with the most information to be able to get what they need.
It's so hard. And especially during COVID where everything was like a shortage. I was just really happy that we had everything in stock for them to even drive over and get for their lenses when the freight shipments and everything was going crazy online. So yes, and QR codes are great, pictures are great. So that way they know exactly what they should be doing. Some of the provider challenges are, how to set your fees. how to handle unhappy patients, how do we improve our skills, how do we recruit new patients, how do we train our team, how do we get paid, right? We're not going to go into billing and coding too much in this lecture. That's a whole other 1 hour, 2 hour course that we could get into. But one way to find new patients, right? Where do you find these scleral lens patients at? A lot of times I just recruit them from your own patient base. So a lot of patients that are just walking in the door for their annual exams, they might not know that scleral lenses are an option. Maybe they tried gas perms way back in like the 80s, 90s, and they just dropped out of them. And they just thought, this is the best my vision is going to get. And your own patient base a lot. That's where I found most of mine when I joined private practice is my own primary care practice. And it's really smart just to begin with maybe high hypertropia, dry eye, mild cones, really kind of get your feet wet. And then once you get a lot more experience, you can jump into more of those complex fits. So even just starting out with something that's maybe like a -10 patient or a little baby cone, something like that. A great way that I have found a lot of referrals is actually just by promoting myself to local ophthalmologists and optometrists. So just going around and telling people in the area that you fit lenses. Ophthalmologists usually, they're not wanting to fit these lenses. And a lot of times they don't have an optometrist on their staff that wants to fit them. So just going around introducing yourself. Most of my doctors in the area have been so receptive. They're like, wow, thank you for letting me know that you're here. I'll send them all your way. They're more than happy to co-manage all these patients with you. Scleral lenses are such a growing market, and it can really help to set yourself apart, whether you're a new grad or you're a new doctor to a group practice, or maybe you just want to, add some excitement to your primary care life. It's a growing market, and there's so many patients out there. It's such an underserved need. And it's super fulfilling. So having patients, give you testimonial videos or Google reviews, it's kind of awkward to ask for a Google review, but unfortunately, like that's the world that we live in, right? Mm-hmm. So when patients are super, super happy with me and they always just say, what can I do? What can I do to thank you? Like, what can I possibly do to thank you? And I just say, well, what you could do that's really easy is if you can just write me a Google review and just say something about the word scleral lenses or keratoconus. That way, when other patients are Googling and trying to find an answer to their problem, they'll come across my practice and then they'll read your story and they're like, wow, that's really smart. So it doesn't have to say like, hey, give me a 5-star review. I kind of spin it around to say, I just want to help more people. And the hard part is they don't know how to find us, and everyone just goes on Google. So if you can even have someone just, put in those keywords in the Google reviews, patients love sharing their story. They're super happy. And then just looking at team training, I know we only have a couple minutes. A lot of the companies will actually send out reps to help train your staff. So they'll do INR training. There's webinars on the GPLI website that your staff can watch about billing and coding, and just educate staff. Let them know that, this is a premium service. There is going to be a little bit more chair time. Don't schedule them in like a 5-minute contact lens slot, let them know the general lingo about scleral lenses. So that way when patients call, they know how to schedule them appropriately. And if the staff is excited, then the patients are excited too. So you want the staff to be pumped up about it. You want them to, share the wins with your patients. And also maybe give your staff a chance to wear some sclerals. I think you might be surprised by how much they like them. I have my front desk member. She got fit in sclerals, so she can say, oh yeah, I have those too. I wear them also. And then patients are like, oh wow, maybe it's not that intimidating, Mary wears them at the front desk. So it just kind of gives them a little sense of encouragement to even have maybe a staff member that wears scleral lenses as well. So I know we have to wrap up in about a minute. So I don't know if we're going to pop on for any more questions before we get kicked off the call for our COPE lecture.